When I started practicing phlebology, my mind was geared toward learning any and everything I could about venous pathology. I soon found that this was a very complex disease process, and I had this hunger for learning more and more knowledge. When it came to being a patient advocate, that's really what led me to going to the ACP. The American College of Phlebology offers an annual congress that you can go and learn about different new things, meet with vendors, and be on the cutting edge, if you will, of venous disease management. It just so happens that I attended a reimbursement and coding seminar, and a couple of the people on the panel, I'd actually done some insurance work for them. And I went up and I talked with them afterwards, and I said, you know, I have a little bit of knowledge in something called ERISA. ERISA is an insurance, if you will, it's a patient and physician rights, if you will, but long story short, it was a tool that I could use to help patients get benefits from greedy insurers, if you will. And in 1 year, I proved to develop a process that was very effective in helping patients get the benefits that they needed. And next thing you know, I offered to help educate people to this process, and I'm being given a couple of different speaking opportunities, and from 2005 till now, I've been speaking largely at first on insurance operations and being a patient advocate, how a doc in a tough market could still communicate effectively with insurers and avoid financial surprises to their patients. What that led to a couple of other things that got me more involved with the American College of Phlebology. One, when I decided to start my own practice, I had undergone a change in an insurance policy where I could previously take patients that had symptomatic lateral thigh complexes and get insurance approval for them, and they had benefits for it. And a major carrier decided that they were no longer going to do that. In fact, declared the treatment that we were offering, which was chemical ablation of the lateral thigh complex, in patients with symptoms, not cosmetic patients. They decided they weren't going to cover any of that. I developed a protocol, went to the 2006 annual Congress. This is the first year that they had a foundation event. I had determined before I went to the event that I wanted to contribute to the foundation. I thought that the American College of Phlebology was going in the right direction for venous education. I thought they were going in the right direction when it came to relationships with industry. And I felt that if I was going to support an organization that could enhance awareness of venous pathology and venous disease, that this was the one to be with. But I took a research protocol to that event. I went golfing with a foundation event, met a lot of people whose names I knew, but never really sat down and talked venous pathology with them. And you know, one thing leads to the next, and you're just having fun talking in a social environment. But what came out of that was support for a research project that not only helped change the way insurers may look at superficial disease in patients with normal saphenous veins, but it really helped me find a home, if you will, a place that I feel comfortable talking to people about venous pathology anywhere in the world. I go to international conferences. I presented 2 different protocols in Monte Carlo in 2009. I'm getting ready to go to Paris for an invitation where I'm asked to speak on this topic of this research protocol. My career is kind of developed to the point that I feel I can still learn something every day, but I'm also one that's contributing to the field, bringing new science to bear, working collaboratively with other providers throughout the country or internationally to answer questions in the field. And it ends up being much more fulfilling. It's fulfilling enough to help patients get a great outcome. It's more fulfilling to know, however, I can use other tools, other knowledge that I have to enhance other providers' ability in their market or have them understand better ways to treat a particular condition. And over the course of the last 9 years, I've been actually treating veins longer than I practiced emergency medicine. And I don't see how I could turn back. There are a number of issues that come to bear when it comes to treating patients. It's first being their advocate, it's second being safe so that you don't have complications, and delivering those outcomes. But there's a lot of questions that have to be answered, and the only way a lot of these things are going to be answered is if there's a collaborative effort among societies, and certainly a partnership with industry and providers to answer questions about efficacy, quality of life outcomes, patient-reported outcomes from the different things that we do. We're entering a new era of medicine, and collaborative work is going to become ever more important if, in fact, what we do is going to be perceived as truly meaningful. I think over the next 5 years, we're going to see pressures put on the specialty that will force people who are just dabbling in treating veins to become more serious about it and get credentialed. I think what it's going to mean is greater quality of care will be delivered. Technologies continuing to evolve, becoming lesser and lesser invasive technologies. So not only should the quality of care be better, but the treatment options might even be less painful than they are today, which are not very painful, and even may deliver better outcomes. My crystal ball has always been cloudy, but in a perfect world, I would like to see the pool of providers become more educated, have patients as their primary focus, and become as credentialed as they can be. And if they are credentialed, that means that they have a certain level of knowledge that meets a threshold to treat veins. It means that ultrasonography performed in any vein practice would be done by qualified personnel. I think if that's done, we're going to lessen the risk of misdiagnosis, we're going to enhance the quality care that's being delivered, and with that, I can't see how outcomes wouldn't be better for patients.